So it's really fun, and I'm pleased to be able to introduce Dr. Azadeh Yadollahi, whose name I can finally pronounce. She started off her career in Iran, and then she moved to Winnipeg, where she did her PhD in electrical and biomedical engineering. She actually developed a home sleep apnea monitor similar to ours, and she's actually developing that now. She came to Toronto to work with me as a postdoctoral fellow because she wanted to learn more about medicine and about human physiology, and I must say she came with a great reputation, and she more than lived up to it. She's been extremely productive, imaginative, and energetic, and I'm very pleased to introduce you to Azadeh.
Good morning. It's a pleasure to be here and to share what we're doing at Toronto Rehab with you. And thank you so much for the very nice introduction. I'm really flattered, and thanks for having me here. So, as Dr. Bradley mentioned, my background is in biomedical engineering, and then I learned sleep physiology here. And what we're trying to do is to see if we can engineer better sleep. As you're all aware, the main goals or the main themes of research at Toronto Rehab and our mission at Toronto Rehab are around three main goals: to prevent injury, to restore function, and to enable independence. And what we are doing in my team at Toronto Rehab is more focused toward the first goal, to prevent injury. And we are trying to do that by trying to improve respiratory disorders during sleep. And Dr. Bradley very nicely talked about the details of the sleep apnea, how the pharyngeal airway narrows during sleep, and how the most common treatments for sleep apnea is to have continuous positive airway pressure, which basically applies positive air to the airways to keep the airways open. And no matter how sexy and nice it looks like, the big challenge with that is up to 80% of the patients are actually not using it properly, either not using it at all or not for the whole night. And that is a big consequence, because given the fact that the sleep apnea is associated with very increased risk of stroke, hypertension, and heart disease, and knowing that many of the patients are not using, there is a big challenge to try to find alternative treatments for sleep apnea, which will be more affordable or more useful than the CPAP. There are other disorders, respiratory disorders, which are common in the population and get worse at night. And one of them is asthma, which is usually thought that is very different from or independent of sleep apnea, because asthma is a problem of the small airways, and it's a reversible disorder. So here is a sample of a normal airway in the lung. And this is what happens in an asthmatic airway. And as you could see, it is narrowed. And this is what happens during an asthma attack, that the smooth muscles around the airway get contracted to the point that they're almost locked, and they keep the airway so close that the person cannot breathe. And the solution is to have bronchodilators to keep the airway open. But many times during the asthma attack, those bronchodilators may not work. And the question is why? So here is a video that I'm going to show you of two slices of the tissue from a healthy subject of the lung tissue and also from an asthmatic tissue. And what is going to happen, this is a video of 60 times faster than the real time, but what we're going to see is they apply histamine to the tissue to contract it, and then they try to apply bronchodilator and see what happens. And this is a healthy subject. So, please play. So you see that it's contracting now. And now what happens is that they're trying to give a bronchodilator. And one of the best things to keep the airways open, or bronchodilators, is to take a deep breath. So whenever we feel a shortness of breath, we take a deep breath. And that's what they're trying to do, to see what happens if they simulate deep breath. And they're basically mechanically stretching the tissue to simulate that. and see what's the response of a healthy tissue to that. So here we have narrowing of the airway. Now simulation of the deep breaths by these at 60 times of the real-time speed. And as you could see, the airway opens up almost to what it was. So taking deep breaths can overcome the bronchoconstriction. Now let's see what happens in an asthmatic tissue. And as we could see, even when there is no problem, the airway wall is thickened in an asthmatic tissue. There's lots of edema around the airway, and it's much narrower to even start with. Now here is when they apply the histamine, and the airway narrows. And now when they do apply the deep inspiration, nothing happens. Not only the airway doesn't open, in some cases even it gets narrower. So the deep inspiration, which are one of the best bronchodilators, actually act reversed, and they act like a bronchoconstrictor. And one question is why? Why this is happening? The other common respiratory disorder is chronic obstructive lung disease. And as Dr. Yan mentioned very nicely, that's one of the very common disorders. It's again associated with the small airway narrowing, but a narrowing that is defined by irreversible, so it cannot be reversed by bronchodilator. And that's a traditional definition. And again, that is one of the common respiratory disorders that gets much worse during sleep with a very high overlap with sleep apnea. So although traditionally it is assumed that these three disorders are very different from each other, one is from the pharyngeal airway like sleep apnea, and the other two are related to small airways, but very different physiological mechanism, there is growing evidence showing that this is not the case, that there is actually a very high overlap between these disorders. They have common symptoms, like their symptoms are getting much worse during sleep or when someone is lying supine. It is common in asthmatic to have coughing and wheezing during night to the point that it disrupts their sleep. And in one study, it was shown that most asthma attacks that lead to death happen during sleep. So what we're trying to do at Toronto Rehab is to see that whether a common mechanism could contribute to all these disorders at the same time. And it comes from the very nice work that Dr. Bradley mentioned in his presentation, that during the day, because of the gravity and lack of activity, fluid and extra fluid accumulates in the legs, in the interstitial tissue. And when lying down to sleep, that fluid is moving out of the legs, going to the upper body. And we all have a lot of evidence knowing that the fluid which is accumulating in the pharynx and in the neck is actually increasing the risk of sleep apnea. So the main question that I had was, what happens in the lung? If the fluid is getting into the airways of the small airway, like in the case that I showed you in the asthmatic subject, could they contribute to the thickening of the airway wall, narrowing of the small airway, and worsening of the asthma symptoms during sleep, or even contribute to the worsening of the effect of deep inspiration in asthmatic? So this is the base of the research that I'm working on. And my research is in two main areas. The first one, which is the basic science and physiology, is to investigate the role of posture and sleep on the pathophysiology of airway narrowing during sleep. And the second part, which is more translational and toward commercialization, is to develop convenient and portable devices to assess breathing disorders during sleep, and to develop personalized treatments for improved management of respiratory disorders during sleep. So for the first goal, one of the very first things that I did when I joined the Toronto Rehab was actually to develop a system so that we can measure the movement of fluid in different body segments to see how the fluid is moving from the legs, gets into the thorax or in the neck. And it's based on a very simple physics law that all the fluid in the body is a good conductance of electricity. So if you measure the impedance of a segment like the leg, that is inversely related to the amount of fluid in that segment. So when the fluid is moving out of the legs, the impedance of that segment is decreasing. So if we measure increasing. So if we measure the impedance and we know the shape of the segment, we can estimate the amount of fluid in different body segments. And this is, in fact, the first system that can measure the neck fluid volume continuously and non-invasively. So as mentioned, we use this system in different studies at the sleep lab here, and we show that overnight fluid moves out of the legs and accumulates in the legs and neck. The higher the increase in neck fluid volume, the more severe is the sleep apnea, and in men, fluid overloading during sleep induces or worsens the sleep apnea. On the other hand, we could think of new treatments for sleep apnea by controlling the fluid retention. So we showed that reducing fluid in the leg, such as diuretics, wearing compression stocking during the day, and exercise or dialysis improves sleep apnea. And these are all the studies that Dr. Bradley mentioned, the base of them. We also showed, and you're the first to show that in asthmatic, fluid accumulation in the thorax narrows the small airway. And that could be one mechanism that contributes to the overnight worsening of asthma in a patient with nocturnal asthma. And these are all the people who did a great job and contributed to all these research in terms of the role of fluid shift. And what we're going to do next is actually to try to improve this system. And we're collaborating with an industrial partner who is based in Toronto called Mayan to develop and commercialize an affordable and portable device to assess tissue composition. So we're trying to develop something like socks that can measure fluid in the leg. So it would be much more convenient. We're also trying to develop devices and to assess respiratory disorders without having the people coming to the sleep lab. And this is in collaboration, this research with Tech that Dr. Bradley mentioned, and they've shown remarkable work in terms of how we can use respiratory sound and breathing sound to develop and monitor sleep apnea. So we're working closely with them to actually develop the second product of the company, which we call it Patch, which is a small device including a microphone and an accelerometer that we can place it over the neck or over the chest, in this case over the neck. And it can record respiratory sound, it can record heart sound, and also the body posture. And the goal is to develop and commercialize a more convenient wearable technology to not only diagnose respiratory disorders during sleep, but also its consequences. Because we have a very good quality of recording of the heart sound, and we could assess the cardiovascular or cardiac outcomes of the sleep apnea. And as Dr. Bradley mentioned, actually this is based on the research that I've done during my PhD at University of Manitoba, that we show that when we record the sound of breathing over the neck and use that to detect sleep apnea, it has a very high accuracy relative to the gold standard polysomnography. And that was one of the very best things that happened to me, that the technology that I developed at University of Manitoba was actually licensed by Tech to be commercialized here and really giving a life to that technology. And now we're working on that. We're trying to move forward and then do more with the sound. Because if you think of the sound, there's a lot of information in the sound. Think of the speech, how much information we can get from the speech. The same thing happens with the sound of breathing. If we look at the snoring, although it is quite annoying, but it gives a lot of information about the physiology of the airway. Think of the airway as an instrument, as a pipe, that is, by the flow of the air, the sound is generating into that. So if there's any change in the shape of the airway, that can be reflected in the sound, like the snoring or the normal breathing. And we could use these sounds as a way of imaging of the airway. So instead of having someone to go for an MRI during sleep to know what happens to their airway, or put pressure sensor in the pharynx to see what's happened in terms of the narrowing of the airway, we could think of looking at the snoring sound to assess the airway physiology. And that's what we're trying to do. So what we did was to actually develop a model of the airway. And this is like a very simple model as a proof of concept to see what happens if the airway narrows. We all know that if you have a pipe, like a straw or a pipe, and if you blow in the pipe, if the pipe is narrower, the intensity of the sound is louder. On the other hand, we all know that if the length of the pipe increases, the resonance frequency in the pipe is decreasing, and that's the base of all the pipe instruments. So that's what we did. We recorded the snoring from the patients during sleep, and we also measured their airway size in terms of cross-sectional area and length. And what we showed, both by simulation and also the data that we recorded, was that in patients who had more narrowing in their airways, the intensity of the snoring was louder. And those who have longer airways, the resonance frequency was higher, which means, those who have longer airways, the resonance frequency was smaller, showing that we could use the sound not only to know if someone is snoring or have a sleep apnea, but also to develop convenient technologies for the assessment, dynamic assessment of the airway during sleep, which can lead us to develop better treatments for sleep apnea, both in terms of diagnosis and also what causes sleep apnea in different populations. And this is what we're doing. And this is what we're hoping to get by looking at the sounds of both respiration and heart sound. We are working on developing advanced algorithms to diagnose sleep apnea over a long period of time. So we don't think that the sleep apnea should be detected only one night. This should be over a long period of time. And also how this is different in different patient populations. We're trying to develop an acoustic model of the pharyngeal airway that can help us to have better diagnosis of sleep apnea and what causes airway narrowing during sleep. To predict the risk of sleep apnea, such as cardiovascular disorders or this excessive daytime sleepiness. We all know that the sleep apnea is associated with four times increased risk of car accidents. And also how we can use the sounds to have a better understanding of the physiology of the airway, which could help us to predict the optimum treatment for the sleep apnea. At the moment, it's more of a try and error. And the last one that we're trying to work on is try to develop personalized treatment for improved management of respiratory disorders during sleep. And again, this comes from the physiology that we're working on based on the fluid retention in the leg. So as Dr. Bradley very nicely mentioned, one of the best and most effective ways to reduce fluid retention in the leg is by activating the calf muscles or increasing the pressure. We showed the effects of compression stopping and exercise, but we all know that we spend a lot of time sitting. We spend more than 10 hours or 8 hours of the day sitting. We have the population who have mobility impairment and they necessarily can't walk as easily as the rest of the population. So what we're trying to do is actually to develop a new device to use electrical stimulation or surface electrical stimulation to activate calf muscle and simulate walking. So what we have done, and we showed my PhD student, is he actually randomized subjects to 2.5 hours of sitting with active electrical stimulation to basically simulate walking, or just sham electrical stimulation that they felt tingling, but there was no effect. And they lie down for an hour to see what happens. And what we found was that when we looked at the changes in neck fluid volume and also neck circumference after lying, after active electrical stimulation compared to the sham, the amount of increase in neck circumference or the increase in neck fluid volume was reduced by almost 1/3, suggesting that these could be an alternative treatment for sleep apnea. And this is where we are hoping to go. We were so lucky to get funding to develop a new laboratory at Toronto Rehab called the SleepDB, which is funded by Canada Foundation for Innovation and Ontario Research Fund. And this is going to be the first soundproof laboratory to examine sleep disorder breathing. So we will have all the equipment and facility to assess the sleep, like a full polysomnography and portable polysomnographies. We have all the clinical assessment to assess the lung function in the same room, and also a state-of-the-art ultrasound to assess the cardiovascular outcomes of the sleep, all of them in the same room. And the beauty is that the whole thing is located in a soundproof laboratory. So we can develop all these acoustic technologies to be able to replace these gold standards with more convenient devices. And the hope is to really change the way that we look at the sleep disorders. I would like to thank all the collaborators and also the funding that without these help and support, it was impossible to do any of these research. Thank you.